Thank you for joining us today. My name is Lily Wang. I'm the manager of SEAL at Spark, a Center for Social Research Innovation. Welcome to today's Spark Talk, Constructing Mental Health Research Among Immigrant Communities with Zoha Salam. So I'd like us to begin by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands where McMaster stands. To say that is to acknowledge the debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. So our speaker today, Zoha Salam, is a third-year Ph.D. in the Global Health Program. As a social epidemiologist, her dissertation explores how the intersections of immigration and mental health policies along with systemic racism, shape access to mental health care services for racialized immigrants within Canada. She brings work experience from local organizations such as the YMCA, ODPRN, and government or institutions like the Ministry of Health, Ministry of the Solicitor General, Ministry of Citizenship and Multiculturalism, as well as global experience with the World Health Organization. And without further ado, over to you.
Thank you, Lily, for introducing me. I'm very excited, but also nervous for this talk. Well, thank you all for coming today. My name is Zoha. So today's outline consists of who am I, because I want to situate myself within the work that I do for obvious reasons, and also sharing where I come to in the work that I do. Because for me, a lot of the work that I do, so many aspects of myself exist in it, for obvious reasons. And a key component of the talk today is centering on reflexivity and critically thinking about how this shapes the work that we do. I'm going to be talking about the making of an immigrant and broadly discussing Canada's immigration relationships. I'm going to be talking about the existence of mental health, such as the DSM and how culture came to be in it. We're going to be talking about what does racism have to do with accessing mental health care in the context for racialized refugees and immigrants over here. And then we're going to be talking more about ethics boards and how they sort of contribute to the problem that we're looking at. And then we're going to be talking about research in you and what does this mean when you conduct research on this topic with certain populations. So the goals of this talk are, well, there's four, but technically I believe there's only one main one. So number one is to encourage you to think more critically about mental health systems. Second one is to understand where medical racism comes in the process for racialized immigrants. Number three, to think differently when you conduct research at these intersections. And lastly, number four, which I think should be the only one, I'm not going to leave you with answers, but I'm going to leave you with more questions, because I think troubling the field and where we work and do our research in is important in moving forward with what we do. So who am I? I am a first-generation Punjabi immigrant. I was born overseas and I came to Canada before 9/11 happened. I grew up in a Muslim family, so coming to a country and then experiencing the aftermaths of 9/11 over here in Canada was a very interesting experience that definitely did shape the world and how I interact with the world over here. I am a mental health service user myself, so my relationships with the mental health system, or broadly speaking, has been troubling, has been interesting, has been positive too. So it's a very fluid type of relationship that I've had with it. My family and communities all have had notable experiences of mental health and interactions with the mental health system. For example, when we think about, sometimes when I see research that's being done on South Asian communities or just racialized immigrant communities in general in Canada, sometimes when I read these studies, I'm a bit concerned and I'm taken aback, because when I read the interpretations or qualitative research, I just am quite disappointed, and I think like, well, this is not the full story that exists over there. For example, when I talk about my community, I come from Windsor, which is a really town. It's this really small town within Southern Ontario. I was raised over there and I lived there for a good chunk of my life, and then I moved to Hamilton. Some of you may be familiar about Windsor, some of you may not, but Windsor is a heavy town with the automotive industry. So many people within my community, within my neighborhood, were employed by that sector. And then when layoffs happened this produced a lot of certain negative consequences because obviously people's financial means were cut. When we think about mental health and all those types of things, I knew that my community suffered very differently compared to those of my white peers, for example, right? After the layoffs happened, there were some incidences where there was an attempted suicide, for example. The story that people tell within our community to people outside always was like, oh, so-and-so was driving back home from Toronto and he fell asleep on the wheel. But that wasn't the case. We all knew within the community what the truth was, but we told a very specific story to outsiders so we would protect our community. And so much of that was precipitated because the layoffs that happened in the automotive industry. So when I think about people who live in my community, obviously there's a mixed range of people who work. And the automotive sector, this included people who would be working on the beltline, like putting things together, or people who are engineers. So it's a wide range of experiences that happened. And when it comes to research, for people who are uninitiated of my community or don't understand my community or recognize my community, if they were doing projects on mental health, they would be coming outside, looking in and saying like, well, they don't get care because, you know, it's stigma. It's a cultural reason, when not realizing the precipitating factors of economic distress that contributed to that decision that one community member made that day. So that is just some context that I'm providing to you about where I'm coming from and how I'm going to be interrogating a lot of the work that we're talking about today. So work-wise, I'm a senior program and policy analyst. That's my day job within the Anti-Racism Directorate. I feel like this is really important for me to say because my views do not reflect those of my employer, as I'm here today as somebody from McMaster. And there's something that I'm going to be sharing today, which some of you may be familiar with what popped up in the news. So I'm just putting that out there. And I also have been teaching health sci, racism, and health since last year, since the course was launched. So this gives a good idea of where I am, where I come from, and what I'm going to talk about. So let's talk about the immigration experience or settlement. So I'm going to push this all back to you, since this is an interactive talk. Feel free to drop this into the chat. How are immigrants perceived? What are your opinions? Or what are some, experiences that you've had or conversations that you've overheard about how immigrants are discussed or talked about? Sometimes as outsiders, yep. Sometimes very patronizing. Yeah, those are all really interesting ways of thinking about how immigrants are perceived, and oftentimes this reflects a certain discourse or rhetoric. Dennis mentioned no lack of Canadian experiences. Yes, that signals a very economic lens about how immigrants and refugees are perceived. What's really interesting over here is the idea of sometimes it's outsiders, like for example, like there's the concept of having like the idea of the perpetual foreigner. No matter how much we remove accents from the way that we speak English, no matter how much we westernize our names, no matter how much we change our dress, we will always be seen as a perpetual foreigner, right? And that is through the process of racialization that the immigration system in Canada, and broadly speaking in the West, perpetuates. Norma mentioned criminals, rapists, yep, the Trump rhetoric. I'm going to bring that up sometime later as well to talk about. So this was a newsletter that was sent out about a certain program and organization that exists over here in Toronto called Frontlines, and basically it talks and it reads organizations, sorry, I'm just trying to move something on my screen. Yeah, organizations such as Frontlines are crucial to York's Southwest End. They have fantastic programs for youth that will assist them in the future to integrate into society. I look forward to working with the team at Frontlines and continuing to strengthen the relationship that we have. There's a lot going on in this, given the selection of the photo, who's in the photo, what's happening in the photo, and how this is a very interesting phrasing of this, like assist them in the future to integrate to society. We don't know what the intention was behind this, but even the fact that, the word integrate is used, meaning that these people need to be molded and changed into having values, or the way that they move into the world over here in Canada needs to be changed extensively. So this, anyways, moving on. So these were some, this was part of a poster campaign that was done by Costi in 2020, I believe, and they had a few of them up until later in the year. I've seen them a lot, like when I used to go to work in the Ministry of Health on the TTC. I saw these posters smattered everywhere that I went. And I just want you to, I'm just going to go ahead and like read it out. Like it says like, I am a new Canadian. And it states their name. It states like when they arrived in Canada. And at the bottom, both of the shared posters have, it says newcomers like Cheyenne make our country strong and more diverse. Costi provides opportunities for success, helping to make Canada one of the greatest countries in the world. And the same is repeated on the other poster. When I saw these posters on my way to work every day, it infuriated me so much, because so much of this is centering on the idea of the potential labor and economic output of these people who come over here for seeking better lives and opportunities. So when you have widespread campaigns of this plastered everywhere, very high in a highly visible area, such as like on the TTC, what does this say? What does this internalize for people who come over here as immigrants and may not be as prosperous or have had better opportunities? What does this say to people who have certain ideas of immigrants? Like, it's a very interesting way of perpetuating the idea of the foreigner and also perpetuating ideas of like what a good immigrant is. But yeah, just take some time to like look at this two sets of posters. There were posters that featured women as well. I don't think I ever came across a poster that had like a woman wearing a hijab or like a niqab or anything else, but it just shows like, for example, like they're very dressed up, like they have suits on, they have, yes, exactly, like the productive worker, right? But it goes to show like how certain imageries and even how you're appealing to the wider public and what we're like, right? What we're supposed to be like. So let's talk about Canada's relationship with migration. I'm just going to go over this like quickly and give some brief points. So I'm just going to start with the 19th century. So it was mainly an open door policy that was largely unrestricted, and this encouraged white immigration to Canada, notably to the settlement of Western Canada. So Canada, however, was not open to all. The first Immigration Act passed in 1869 and specifically discriminated against people on the grounds of class and disability. Immigration was also discriminatory on the basis of race. For example, in 1885, under the pressure from British Columbia, the federal government imposed policies to restrict Chinese immigration, like a head tax, and later on the Chinese Immigration Act of 1923. These explicitly racist measures directed at the Chinese continued up until the 1940s. So even white migrants were discriminated on the basis on their ethnic background. Like you have Anglo-Saxon settlers from Britain and the US were seen as the best fit, whereas Italians and Greeks were viewed as harder to assimilate and thus less desirable. So in the early 20th century, you had racial and national restrictions. So after large cohorts of mostly European immigration came to Canada between 1903 and 1913, and a series of political upheavals and economic problems that followed, like the First World War, and much more restrictive immigration policy was implemented. Under a revised Immigration Act in 1919, the government excluded certain groups from entering the country, including communists, Mennonites, and so many other groups as well, and also nationalities whose countries had fought against Canada during the First World War. So the federal government also applied increasingly arbitrary restrictions on the basis of race and religion. In 1911, the government considered banning Black immigrants, but ultimately did not follow through with the idea. And this was basically placed by Wilfrid Laurier, and he stated that which race is deemed unsuitable to the climate and requirements of Canada. So this idea of thinking pathologizing Black bodies or Black immigrants in general and saying like, you know, they physically cannot come over here because they won't be able to tolerate the cold climate. That idea is rooted in medical racism, and so much ideas and rhetorics at that time came from, you know, perpetuating and justifying slavery. So when we think about medical racism, it wasn't just a way of like perpetuating unequal access to treatment or horrible outcomes of care. It also was used to justify things such as immigration laws because of pathologizing bodies and saying which ones were good enough to come, which ones were healthier, which ones were better, right? So that's just another way of how so much of this creeped in. And there were obviously incidents, like, for example, that included having anti-Semitism, like, for example, in 1939, Jewish refugees fleeing from Nazi Germany aboard the MS St. Louis were denied entry into Canada on arbitrary grounds related to their Jewish background and were turned around and refused entry. And then within the post-war period, we had some interesting things, like Canada's restrictive immigration policies began to slowly and gradually ease after the Second World War, partially due to booming economic growth and partially due to changing social attitudes. So in 1947, the formal ban on Chinese immigration was ended. However, in 1952, a new Immigration Act maintained Canada's discriminatory policies against non-European and non-American immigrants. And it wasn't until 1962 that the federal government ended racial discrimination as a feature of the immigration system. And in 1967, a points system was introduced to rank potential immigrants for eligibility. This includes race, color, or nationality were not seen as factors in the new system. Rather, things like work skill, education levels, language ability in speaking French or English, and family connections were main considerations. And then obviously in 1969, Canada signed the 1951 United Nations Convention related to the status of refugees and the 1967 protocol. So we had a lot of things, so much from that. And then when we think about, for example, refugees specifically, like when we think about, so much of it was like the idea of like countering the ideas of terrorism, like the terror that brown refugees or immigrants would bring. And there was also some other things as well. Like, for example, in 2004, Canada and the United States signed the Canada-United States Safe Third Agreement, and this agreement recognized both countries as being safe third countries for asylum seekers, as which it was possible for both countries to prevent asylum seekers from coming into other countries and applying for refugee status. And we've seen some consequences of that, like, for example, at Roxham Road and the decision that was made over there very recently. And then under the conservative government of Stephen Harper, the rhetoric against refugee claimants was intensified. Many groups of asylum seekers or claimants were accused of being bogus refugees and fraudulent. And this government viewed many refugees as individuals trying to take advantage of Canada's immigration system. And we've seen so many negative consequences of this. Like, for example, in 2012, the bill C-31 that drastically restructured Canada's refugee and immigration policies, which introduced amount of restrictive policies that were put in place. So when we think about the Canadian context, like from the 2006 census, obviously should update this to include the newest one, but hold on, wait, why is this not? 21 or 0.9% of Canada's population consisted of broadly of immigrants, and this was mainly economic immigrants, and then the other categories so on and followed. And then from 2011, 2006, 1.2 million new immigrants had settled in Canada. And then we have seen drastic shifts in migrant populations over time, obviously based on how immigration policies have changed and also certain incentives provided as well. And we also had different waves of refugees in Canada, for example, like the Black Loyalists, Europeans, Vietnamese, Syrian, Afghan, and then Ukrainian most recently. And then currently more than 1/5 of Canada's population belongs to a racialized group. Just for some context, I'm using the word racialized instead of the legal term visible minority because I find that term very contested for obvious reasons. So that's why I'm saying racialized. And then one cool fact that I always think about is, like, by 2032, 1 in 3 Canadians will belong to a racialized group or identify with one, which shows how Canada's population is slowly changing over time and what the trajectory will look like. So when we think about migration as a determinant of health, we think about how, for example, one's circumstances of departure often shapes their outcome in a host country. And there's stark differences between migration classes. For example, if you come over here as a dependent versus if you come over here as a government-assisted refugee. There's so many differences between that in terms of the amount of support that's available to you, but also how heavily involved the government will be involved with this. And also the funding that's available too for certain resettlement programs as well. We know that other racial groups have different outcomes based on systemic racism that they encounter over here in Canada. Like, there's tons of discussions that I've had with my peers and also my participants about, like, how when coming to Canada, it was such a different process for them because they were now being labeled with a different identity that they never existed or interacted with back where the country that they came from, for example, right? And this has shifts in how people interact and experience the world and access services and so on and so forth. And the process of migration itself has so many stressors in the entire process, right? Like, for example, the stories that refugees have to produce in order to be seen as credible, and the stress that places upon them, and also the internalizations that they bring from that, right? And Canada's resettlement policies favor the nuclear family arrangement. For many of us who come from countries or organized cultures where we're more, for example, the nuclear family obviously doesn't exist in many of our cultures. This is a form of assimilationist policy. So when we bring communities or people that come over here, it's a radical way of changing communities and shifting them and forcefully assimilating them, right? And also, lastly, when we think about the broad term migrant, right, it's like not really that helpful at all. Like sometimes when you'd be reading research studies, you'd be like, okay, like, is this, what type of immigrant population group are you talking about? Which legal class are you talking about? What immigration class are you talking about? Or sometimes that they would conflate the two interchangeably, and then this leads to very poor analysis. I'm talking about both quantitative and qualitative studies as well. So a lot of contextual knowledge and work gets left out. So we're going to shift gears a bit and talk about the existence of mental health in general. So let me push this back to all of you. What is mental health to you? Lynn mentioned my mental state of well-being. Yes, well-being. Lily mentioned how comfortable I am in my day-to-day life. Yes. Okay. Just going to move on from that. But yeah, like mental health encompasses a wide variety of things. Shiva mentioned emotional and spiritual well-being. It's really interesting, like when you look at the WHO's definition of health, it doesn't encompass things like spiritual well-being, which I find very interesting, but also telling about the construct of health and the way that it's operationalized and described. So yeah, those are, okay, one more. Matthew mentioned personal ease and continuing to exist, but also socially yes, and desirability. Dennis mentioned, I don't have a clear definition of it, and that's one of my questions to this webinar. Exactly, yeah, let's trouble this idea. So we have a wide variety of answers, and so much of it like focuses on like well-being, and I find this one really interesting, expectation of normalcy and desirability. Okay, so moving on. So let's talk about like medicalizing the body before we think about mental health and how we know about currently within the DSM. So when we think about medical systems or just like the field of medicine itself, it had a very colonial origin, to no one's surprise, because it was used to justify things like slavery, indentured servitude, and also forced sterilization of certain groups and communities, right? So colonialism, as an extension, was used to subjugate and control bodies. And this was through the development of the idea of certain races as inferior and biological essentialist beliefs. So as the field of medicine continued to develop, this also pushed the norm of medicalization and standards of practice. Like, for example, when slave revolts used to happen on plantations, many people, or for example, like the owners would say like they're experiencing insanity. And this would sometimes lead into institutionalization or forms of policing that was encouraged, that was deadly for many communities as well. We also had the existence of IQ testing, which led into the idea of eugenics, which has been used time and time again to justify forced sterilization or controlling certain populations. We've also had, through colonialism, banning traditional and localized practices of healing. Like, for example, the passing of witchcraft laws in colonial Kenya. There was also the penalization of indigenous ceremonies in Canada. And also discounting the presence of traditional healers. Like at a point in time, midwives were removed from practicing care and providing care for people who are pregnant or giving birth, for example, right? So medicine has a history of aligning cultural generalizations and behaviors with risk factors of disease, and how therefore it perpetuates a form of medicalization of bodies and seeing which ones are inferior, which ones are fit to work and whatnot. And so much of this, like, for example, when I was like sharing the posters early on that Coastie put out, it shows like, yes, like certain bodies are preferred. And we see that through the immigration policies in Canada with the medical admissibility policy that exists, which has changed and lessened over time. But even the fact that it existed in the first place is telling as it is. So when we think about culture in the DSM, it wasn't until like the fourth iteration that it was like introduced over there. It was initially called as like culture bound syndromes, which I thought was like really interesting. So within the DSM-4, culture bound syndrome was described as recurrent locality specific patterns of aberrant behavior and troubling experiences that may or may not be linked to a particular DSM diagnostic category. So this first sentence, this shows that psychiatric classifications were the result of Westerners' ethnocentric views of psychopathology. Anything beyond their commonly observed phenomena was considered peculiar or exotic, essentially. Many culture-related syndromes are illness-defined or manifested by multiple or heterogeneous clinical psychiatric conditions that are difficult to fit under a single diagnostic entity, and forcing the culture-related specific syndromes into the descriptive-oriented classification system risks losing the unique meaning of the syndromes from a cultural perspective. And then in the fifth iteration of the DSM, it was changed to cultural concept of distress, syndromes, idioms, and explanations. And basically the excerpt for this in the DSM reads, specifically the term culture-bound syndrome ignores that clinically important cultural differences often involve explanations or experiences of distress rather than culturally distinctive configurations of symptoms. Furthermore, the term culture-bound overemphasized the local particularity and limited distribution of cultural concepts of distress. So it basically refuted what was in the previous iteration. In this sentence, this reflects a socially responsive nosology within the DSM, as the parameters of specific diagnoses have changed over time and some have been completely removed. It indicates that a constellation of symptoms is influenced by a cultural landscape or an ecological niche or niche. The concept of importing Western norms and conceptualizations of mental illness calls for further questioning, as there has been no one-size-fits-all approach to when it comes to well-being. So these are just ideas like to think by, because like the DSM has been a very key cornerstone of research and also considered to be the golden standard within North America. And also, you know, when we think about it, like obviously that's changed as time, like for example, homosexuality or queerness and other forms of gender expression were considered to be a mental disorder, and how those things have radically shifted over time, right? So it asks us to trouble of where our knowledge is coming from and why certain knowledge is always held up for truth. So the age-old question, what does racism have to do with accessing care? So, you know, I just went ahead and like put into Google, I got curious and I Googled like, do immigrants, and obviously like these are all the autocomplete suggestions that came up. And I also did one similarly for, do refugees, and the most common things that come up: get free healthcare in Canada, pay taxes. Do refugees get free housing in Canada? Do refugees pay taxes? So there's a lot of these assumptions that come up and how the public perceives us as a broad group, regardless of whatever legal or immigration pathway that we came from. These are certain assumptions that are used. We've often heard of things like saying like, oh, they come over here and they steal our jobs. They come over here and they take up our seats for educational programs. It's like, that's not true. But it also comes up with the idea, it's like, why does this exist in the first place, right? So when we think about the mental health system as we know it, so historically in Canada, it has been through a carceral lens, and this is through the existence of asylums or sanatoriums, for example, and so much of it is very fragmented in general. Like psychotherapy is not fully covered over here in Canada under OHIP, especially. Many people end up paying out of pocket for it, and it's a very costly experience. Even, for example, like the medication that you would get my ADHD medication every month costs me $120. And even through McMaster's health insurance plan that I get over here through grad school, my specific medication is not covered. But I have private healthcare insurance through my place of work, which covers the cost for that. So even thinking about like, here's another fun fact too, like $120, that's my full, that's how much I budget towards my groceries for an entire month. It's like, do I end up paying for my medication that helps me function throughout the day and keeps me well? Or do I end up paying for my groceries? So those are some things that we have to think about, right? Because like many for immigrants and refugees, broadly speaking, there's a wide variety within a class difference that exists. And this obviously shapes access to services and care that we can receive. So for generally speaking too, many racialized immigrants and refugees often end up getting care through a crisis pathway. And many crisis pathways have a component involving law enforcement. A disturbing statistic is that within Canada, or generally, 40% of police responses to mental health concerns often result in arrest. So what does this say for people who are racialized Black and racialized as Black and other? This can lead to very deadly consequences. So the other thing too is like when we think about our carceral lens within the mental health care system, is it truly providing care or is it further dislabeling people? Like, for example, when somebody's placed on a Form 1 and like consequently is kept on hold within a hospital because they're deemed as a threat to the public or threat to themselves, the care that's provided to you within the hospital at that time is very substandard. A lot of people's experiences of receiving care at that time, especially through involuntary services, is noted to be dehumanizing and quite negligent as well. So also like when we think about race and racism in general as well, right? So oftentimes we will see things like, oh, XYZ race like doesn't receive care or services. Well, that's not really the whole story. It's racism that's a key determinant when seeking care, not race, especially in the way that how our system is set up and how it punishes people of certain racialized backgrounds even more. So I want to provide another illustrative example, like based on this title of like this was published, I think about this in a really curious framing about how racial disparities or inequities to care are described and even framed. This title basically reads, Black Canadians more likely to be hesitant about COVID-19 vaccines, surveys suggest. There's a lot going on with this title and it provides really interesting assumptions. Like, for example, this is an example of racecraft, which is a concept developed by Fields. I think their name is, one is Karen Fields and Barbara Fields, who talk about racecraft. So this is an example of racecraft. Here we see racism, access to resources, or in this case, the COVID vaccine, conceal itself and then reappear as race, the attitudes that individual Black people have about the vaccine. So basically, if the problem is the attitudes that individual Black people have about vaccines, then the solution becomes something like public awareness campaigns. So, and it really basically hides the idea of how medical racism or just racism plays a role in shaping access to vaccines or care, in generally speaking. So the concept of racecraft becomes a really important tool when we start dissecting issues or studies that come about simply about like, okay, well, XYZ group doesn't receive care because they have hesitations or certain ideas. It's like, okay, but like, that's not the full case. We have to understand how racism obviously is playing a role, but why are you covering it up, right? So when we think about the generalized documented mental health outcomes of racialized immigrants or refugees, like there's mixed findings on prevalence rates, like, and this is so much as contextualized by groups. And generally it's understood that racialized migrants are clinically underserved for many reasons, such as economic access or finding a provider who's culturally sensitive and adaptive, right? And like I said, we're more likely to access mental health care services through forensics or crisis pathways. And this includes like having the police involved or going to the ER. Many people report negative experiences seeking care, and so much of this is perpetuated by, medical racism or just ideas and attitudes of racism that sometimes providers have, or how racism is built within certain treatment protocols that deny the real life experiences that involve racism for many clients and service users. So when we think about the different manifestations of racism, I based this off of Kamara Philip Jones' 3 layers of racism, but I added a few more things over here. Like, for example, when we have in the context of looking at, mental health care experiences of racialized immigrants and refugees, like we have things like systemic racism, which literally is through settler colonialism, or when we have immigration laws that prevent people from coming in, right? Then we have institutional racism, like how at a point in time, people couldn't get certain education because based on their racial or ethnic identity, or institutional forms of violence that exist, like forced sterilization laws. Then we have cultural forms of racism, which I think is the most common way that comes up within mental health care research. For example, the definition of cultural racism is like that racism that occurs through beliefs that there are generalized intrinsic cultural differences belonging to individuals of one race or ethnicity. While individuals within racial and ethnic groups may have similarities, cultural racism arises in the assumption that everyone in one ethnic or racial group has the same cultural values, habits, and beliefs. And medicine has a history of aligning cultural generalizations and behaviors with risk factors of disease, which perpetuates cultural racism. And this practice has shaped clinical practice and research on health disparities by reducing complicated phenomena to broad and oversimplified assumptions of characteristics and behaviors. Like, how many times have you ever come across a study on, inequities or disparities in mental health care? And so much of it is chalked up to like, well, it's a cultural reason why they don't get care. That is a very racist and cultural racist assumption to make. And when we focus on cultural aspects of individual behavior as sole determinants of racial health disparities, it is misleading and it ignores structural factors that perpetuate disease and tends to perpetuate notions of racial inferiority and negative stereotyping. And then we have the other layer of interpersonal racism, which happens between people, and this could be like between a mental health care provider or their client or service user. And then we have internalized ideas of racism, which, for example, if your entire life you've been told that you're supposed to be the good and deserving immigrant, what does this mean when you end up getting care, right? You may not want to get care because you'll be thinking of yourself like, I'm causing a burden on the healthcare system because I belong to XYZ group and I know that I'm not supposed to be seeking care. So to sort of like wrap all of that up, what I just told you, so like there's so many dominant narratives of migrant populations as hard to reach within research or service provisions, right? So the little image that I have on the side, it's like, are these groups hard to reach, or are these services intentionally hard to reach, right? And when I described like so much of this has the emission of racism at play, like if you're doing research on racialized populations, there is no way that you can, like, you have to analyze it with the assumption that there is racism at play. So you can't just leave it at like XYZ disparities happen and putting me some like nice, odd ratios that come up out of your logistic regression. So, and, there's also the broader discourses of the good and deserving migrant about how this all perpetuates and shapes ideas about who gets to seek care. So now we're going to get into more of the ethics boards and whatnot type of ideas. So when we think about ethics boards and regulations, some of you may be familiar with HIREB or MREB. So many ethics boards were developed as a result of the atrocities that happened in World War II. And they primarily centered on medical and biological research. And much of this, like many of you may be familiar with more macro forms of ethics versus micro forms of ethics. Like macro would be like, what does informed consent look like? Did the participant sign the paper or whatever have you? And then micro forms of ethics look like cultural reflexivity and adaptivity when working with your participants, right? And then consent forms and other forms of routine consent, like they're inherently problematic, right? For many racialized immigrants and refugees, they may be problematic in the ways like, for example, they remind them of things like, for example, surveillance regimes that they came from, and also forms of colonial land acquisition when papers were signed and obviously were changed with nobody had the idea like, wait, I thought I was signing this, but it was end up having that. And also like the idea of like, non-written or verbal forms of consent is always considered to be the non-standard. And we need to start thinking about why signatures are a form of like a cultural fetish that exists within ethics boards. And even when we think about informed consent or what is autonomy, it's a very binary and reductive approach to thinking about individuals and also self-determination and personhood. Like within the context of doing research with like certain populations, somebody could have a bad time doing research or participating in a research study, but also you have to understand what would be the negative impacts of like when that person goes back to their community and says like, do not ever speak to anybody from McMaster University. They will ask you inappropriate questions. I felt belittled by them. So it's not just about one person. It's also about how this creates ripple effects within the community and perpetuates harm. So also, like, when we think about vulnerability in ethics as well, like McLaughlin and Alfaro Velkamp, like they describe vulnerability specific to migrants in 3 ways, right? One is the lack of access of the legal system. Number 2 is dependency on agencies for resources. And number 3 is precarious legal status. So when we think about McMaster's endowment and how much money that they have on their legal team, right? It's like, is it realistic to expect that a participant who comes from a very precarious legal status, that they would even have the same amount of resources to pursue litigation against a large university that has so much money? At a point in time, consent forms essentially become a way of protecting the university from any form of harm that may come from that, right? So when it's encourages us to think about a bit more, what exactly is the intention of the work that I'm doing? And is the ethics board actually, protecting participants? For many qualitative researchers such as myself, I really do believe that ethics boards do not encompass the flexibility and also the fluidity that exists as a consequence of how qualitative research is done, right? And also when we think about immigrants, like they're not inherently vulnerable. They're vulnerabilized through the system that, from immigration, from the racial, like hierarchical, how so much of this exists over here in Canada. And the immigration system is disabling by design. And that's very important to recognize. Like, for example, when coming over here and accessing OHIP, there used to be a 3-month waiting period. So what happens to you within that 3-month waiting period, right? You either pay out of pocket or you get sick and you get worse. So the system is disabling by design for many racialized immigrants and refugees who come over here. So let's change gears a bit and talk about research and you. So racialized populations as a field, there's a really important concept that I think about a lot in the work that I do, and also the way that some of my colleagues do. There's the idea of like normative whiteness, and the best definition is used by Bilge from her article in 2014. It basically describes it. She's like, I untie whiteness from skin color, physiology, or biology, and understand it as structurally advantaged position, a privileged standpoint from which white people view themselves and others in society, and a set cultural practices that are considered to be unmarked, yet unmarked only if viewed from the perspective of normative whiteness. So I pose to you, after reciting this quote, how does normative whiteness show up in your work that you do, in the research that you participate in? I think for me, here's an example, is that how when I do quantitative research, how white people are always seen as the reference group, right? Like, how do XYZ communities compare in reference to white people? Well, yes, it makes sense that people with certain privileges are people that we should be seen as reference groups, but like even then, like it doesn't make sense from an anti-racist perspective of doing research, right? So that is a form of normative whiteness that exists within research, right? Like always assuming as white people as the default. Yes, Lily, that is a really good one. Professional communicative practices. Yes. Norma mentioned translation. Hidden curriculum. Yeah, that's a really important one. That is a really good one. Okay, so we have different ways about how normative whiteness operationalized within the academic context, right? We have things like hidden curriculum, which obviously shapes about who has access to resources at the end of the day. We have things like translation. We have professional communicative practices, like how we are supposed to orient ourselves and communicate. Like for me, I know that whenever I deliver a guest lecture or an invited talk, like I have to be very careful with my words. Like there have been times where I've been told by instructors or professors ahead of time that I can't say the word racism and I should use things like intergroup conflict or racial sensitivities instead. So yeah, I think there's tons of way about how normative whiteness shapes the way that we do our work, but also how we interact with academia as a system itself. So when we think about rethinking our work, so academia generally as a site of whiteness needs to be troubled for many reasons. Like even, for example, how certain words can't be said. Like I know that racism is a really big one that I feel like a lot of people still have contentions with. Like, how am I supposed to talk about racism or racial health inequities when I'm not even allowed to say the word, right? It's a bit confusing and it's a bit puzzling, but obviously like it shows where certain priorities and certain sensitivities lie, which I think is interesting. And then there's also the idea of like the pressure to produce novel findings. I always find this really interesting, especially like when we think about racial health and equity research, is like, you know, having novel findings is like a very extractive and colonial way about looking about how research should be done or is done within our communities, right? If there's truly, when you think about it, it's like there's no such thing as novel research on these issues because you're assuming that the knowledge doesn't exist in the first place, when in reality, these knowledges or experiences have existed for generations within our community. They have lived on as truth. They have lived on as stories that we tell to other people in making sure that they navigate the healthcare system in a way that prevents them from experiencing negative things. Like, for example, many communities are aware about how Children's Aid Society is a detriment to our communities. And therefore, for example, if a mother or if a person who has recently given birth decides to go to their doctor and talk about, for example, experiences of postpartum depression that they're experiencing, they will be very measured in the way that they talk to their primary care provider because they don't want CAS to get involved in their lives. And we know that historically CAS has been used as a tool of colonization, for example, with the RCMP, 60 Scoop residential schools. And also still to this day, we know that Black and Indigenous children are overrepresented within the CAS system. So your research, we need to stop thinking about, you know, the urgency to think about novel findings when in reality, the truths have existed within our communities for generations. There's no such thing as novel. It's only novel when it's out of context. There's a really amazing concept developed by Dr. Ellie Lett talking about health equity tourism, which basically talks about like how, you know, many researchers, racialized themselves and also white researchers, come and parachute within communities and do health equity tourism. And we've seen this like with the intensification of certain grants that have popped up that focus on doing research on racialized communities, right? And there's 4 components to that Dr. Lett mentions in talking about health equity tourism. One is that equity is fundamental. So a community member framework is one that views equity as fundamental goals of its all scientific inquiry related to health, as opposed to an enterprise only tangentially related to their core research agenda. And this has 2 questions posed. Who is represented in the study? For example, the reliance on statistically significant findings to determine the importance for our work generates an environment where the largest groups are regarded as the most important, right? And then question number 2 within that principle is like, how can this work cause harm? Historically, much research has worked on populations rather than with, right? And number 2 is positionality as healthcare praxis, which I think is really, really important and like encouraging reflexivity too, right? So dynamic health equity research engages an epistemological lens that is intrinsically tied to the researcher and bears an often overlooked nexus. Who are you impacts the kind of science that you do, right? And number 3 is collaboration. And just as no single discipline independently handles all aspects of patient care, a research team concerning health equity and health equity should include a transdisciplinary assortment of professionals. And lastly, number 4, sustainability and urgency. When tourists enter a space with an emphasis on quick action, mistakes are often made. The reality is many of the observed inequities are longstanding or acute shocks to an already unjust system, like for example, COVID-19. In truth, few studies have immediate impacts on health equity and often become part of a cumulative evidence that are base used to motivate policy changes. There are no research emergencies, and such expediency can result in deficit-based science that pathologizes communities rather than redistributing power and resources. So those are just some 4 concepts to keep in mind, and also the idea of health equity tourism and how it operates alongside with the concept of normative whiteness. So when we think about reflexivity for bias, it's not something, controlling for bias is never something that's feasible, right? I feel like controlling for bias and even the idea of like bracketing or considering for bias comes from very positivistic ideas of research, whereas in constructivist and transformative forms of research, there's no such thing as controlling for bias. Bias is something that you have to own, and it will exist there no matter how much you do. And positionality is not simply just like navel gazing and listing out, like making a laundry list of like who you are and what you are, right? It's understanding how so much of this comes to. Like, for example, my dissertation committee, at a point in time, it's composed of 4 people, 3 people are white, and 1 person is racialized. But obviously things have changed, but because of that dynamic, I wasn't able to have certain conversations about race that were appreciated or even considered, which really deliberately shifted the way that how I did my work and how I wrote it up, because it very much came to the realization that I was like, I'm writing for a white audience. That is not my intention of what I want to do with my dissertation. And obviously racism needs to be named explicitly, right? Like writing it as discrimination is not enough. So when we, like, for example, like, it's not, even like, for example, when we think about research and how racism happens. Yeah, so, and even just like, it's not developing counter narratives, it's not just about dialoguing with participants, right? It's about thinking about how am I coming to the work that I'm doing, how all of these things that are happening, and how can I develop counter stories and working with disrupting certain narratives that we have seen within research and also perpetuated broadly in policies and discourses about immigrants and racialized populations in general. So these are some questions that I leave for you, right? Like your orientation to the field. Just some 5 questions. Who are you? Why are you here? Who are you responsible towards? What will you do to keep our stories safe? Where does normative whiteness exist in your work? For example, like when I see research that's done on my communities, I think about, you're harming my community, you're harming me, you're impacting how my communities and how my loved ones will ever receive care. So please take mind and understand that some of your colleagues are the ones that are impacted by the work that you're doing, and you need to be mindful about how you enter and exit the space. So I'm just going to stop sharing because I am mindful of the time. And yeah, that is all what I have to say.
Thank you very much, Zoha, for sharing. Do we have any questions at this time? Okay, in that case, thank you all for joining us this morning. If you have any further questions, please email talk2spark@mcmaster.ca. They're separated by periods. We also have a very simple 1-minute feedback survey that helps us plan for future speakers. The link is going in the chat right now. And please visit our website for upcoming events and to see the recording for this talk. And thank you for coming. The slides will not be available on their website unless Zoha wants them to be, but the video will be available. Thank you. Thank you everyone for coming.